Okay, and we're live. Apologies for the slightly late start. We were sitting there ready. It's just the program starts, it kicks in, and then I get the countdown and it doesn't go in. So I was here. Please don't think I'm being insulting to you by making you wait 3 minutes. But anyway, we're here. We're live. It's episode 258 of the Sports Therapy Association podcast. My name is Matt Phillips, creator of unchatlive.com. And as always, this episode is being recorded live on the Sports Therapy Association YouTube channel and Facebook on a Tuesday night at 8 o'clock. So I'm so excited about tonight's show. It's on a topic that I absolutely love and I have loved for years. It set my career really as putting the evidence back into running or putting the evidence back into soft tissue therapy. It was one of the topics that was so hot back in kind of 2012, 2013. It really was amazing. And it's still a topic that is being discussed today, but in lots of different ways. So in this episode, New Perspectives on Fascia, I'm absolutely thrilled to be joined by two leading researchers in fascia from the University of Kent, Dr. Melanie Boucher, lecturer in sport, exercise and rehabilitation sciences, and Dr. Kyra De Coninck, senior lecturer, School of Sport and Exercise Sciences. Before I bring up my wonderful guest tonight, then as always, I must thank my guests from last week. We had a great episode. I always say it was a great episode, but it really was. It was a chance for us in episode 257 to look back and reflect on the STA and Hands-on Hub conference that happened on the 20th and 21st of September. Feels like a lifetime ago. But we looked back in collaboration with the ST School and we talked about it. And we looked at what went well, what could have been a little bit better. And we're so excited about planning for another one. But as part of that, and this is where you, the listener, and colleagues of listener, we need your help. I did mention that there is a questionnaire that we created. And it's a questionnaire where we invite all of you listeners and colleagues to basically answer these questions about what do you want from a CPD conference? Because we kind of said last week that the success of the conference and the feedback we got was simply because we gave the people what they wanted. We listened to you guys, and we did mix it with some kind of education-based approaches and things, and helping you guys be the focus of attention instead of the speaker on the stage. But it went so well. So it works. Guess what? If you listen to somebody, then you can actually help them. Who would have thought, us being clinicians in that? So if you do have time, then please go to the homepage of the ST School or go to the homepage of the sta.co.uk, and you'll see a QR tag on there or a little button to click if you prefer that. And you'll find a questionnaire. It really won't take more than 4 or 5 minutes to fill out. And that is the way we can help you and put together a follow-up conference somewhere in the UK. So we'd love, please do contribute. It really helps us help you. Right then, to tonight's show. Very excited to bring up my guests in this episode entitled New Perspectives on Fascia, Dr. Melanie Boucher and Dr. Kyra De Coninck. Let's bring them up now. Good evening, Dr. Boucher and Dr. Kyra De Coninck. Oh, the name is just rolling off my tongue now. Not one mistake, no? I'm so glad we had that 30-minute training beforehand just to practice the names. Thank you for your time.
Welcome.
It's a pleasure to be here.
Particularly Kyra De Coninck, because this is your first time on the show. And
yes,
so you had no idea. Claire's just gone, yeah, come on, it'll be okay. And you said yes. So you must trust Claire wonderfully, which is nice to see. Really appreciate it. I always say this, I'm hoping, Claire, you've been on the show before and you spoke at Therapy Expo, and I'm sure a lot of STA members remember, but I'm hoping that there's people who are listening now, with a couple of thousand we get downloaded, who have never heard of either of you. I'm sure they've heard of fascia, but hopefully they don't know you, because otherwise, what's the point? We're just in an echo chamber. So, well, hey, you are in my mind. You're my go-to fascia people. So, if you could, what a great label! Your work is done.
I'll put that on my CV.
Yeah, exactly. Matt Phillips from Unchat Live said. But yeah, so if you could, although I'm sure it gets longer and longer each time you have to do it with the amount of work and research and the things that you've done, but a little introduction, a little elevator talk on how you got into fascia and what you do with fascia now. Should we start with Dr. Claire Boucher?
All right. I was going to say Kyra could go first, so I guess I'm up. So yeah, I'm Dr. Melanie Boucher, Claire, and I stumbled into fascia, which you may have heard me talk about before, in that I vocationally was working in exercise referral, working with lower back pain, working in various different kind of health and fitness environments. Had never heard of fascia. Never came up. I think at one point it may have been a little tiny anecdote in an anatomy drawing, but that was it. Finished my undergraduate degree, sport and exercise science, was looking for master's and PhD opportunities with back pain, lying on the sofa with my legs in the air, and saw a Twitter post back in the day that was Kyra advertising a PhD looking into the thoracolumbar fascia and back pain. And my brain went, what is this? Why do I know nothing about this? And that was pretty much what I messaged Kyra, and then here I am. So my kind of interest, I suppose, fell into it through using movement and exercise to help people, and then realizing, okay, well, massage and all the things I'm doing connect up with it. So that's how I got here.
That's wonderful. When was that again? When was that Twitter post? What year were you talking about?
2018, I think I saw the post, and I started the PhD 2019. So yeah, I'm not on Twitter anymore.
I've just started using it again because I've got a newfound interest in communication skills and behavior skills and a new course and stuff. So I've just made a little group of brand new people now just to follow them, because you can create those groups and just follow them. And actually, you know what, it reminds me of the good old days on Twitter when you could actually follow some people and get some good information. I almost feel like doing a follow Friday again or something, just like we did in like a decade ago when we actually remember that? It's amazing. It was so cool.
LinkedIn now. LinkedIn, I've got all the good people over there. I'm in my little bubble, so that works.
No, it's good as well. No, it's true. Okay, well, thank you very much for that detail. And you did do your PhD, didn't you, there, under the watchful eyes of Dr. Kyra De Coninck. See, I've done it already. And since then, you're very much involved with, now you've got undergraduates of your own, haven't you? And you're helping them.
Yeah. So, I'm still at Kent. I'm lecturing. I am still ongoing writing up my PhD. Well, I've written it, but to try and get it published. It takes ages, especially when you're teaching at the same time, but I'm working on that. And I've got some new research projects. I'll give them a shout out, Katie and Daisy. No idea if they're listening. They should be, because they're doing a study on fascia, which they started training last week.
Well, that's exciting. Well, we'll turn that into a little soundbite and then they can put that on their CV.
Right. Come on.
Wonderful. Okay, well, thank you very much for that. So, the person who made Dr. Claire Boucher's future as it is now, which I'm sure she would thank you for. Yeah.
Oh, yeah.
How did you get into fascia then, Kyra? How did that all happen?
My journey started a long time ago. I used to run a sports injuries clinic and was part of a multidisciplinary group of practitioners. And I ended up with a lot of patients who just couldn't find any answers anywhere else. So these were people who had been suffering with chronic pain, both athletes and non-athletes, people who may or may not have been injured a very, very long time ago, but were really suffering with chronic pain, with recurrent pain, with intermittent pain. And I started looking into the nervous system, and it's really the frustration of the kind of theories and ideas and concepts and frameworks that were available, and courses, CPD courses that were available at the time, working with chronic back pain and chronic neck pain, for example, that didn't really answer the questions that I had. And I noticed that some people just working on their bodies just felt so different. So some people, it felt really spongy and very soft, and I could just go into it. People in pain. Other people in more or less the same pain as they presented to me and talked to me about their pain, their bodies felt very different. It's very dry, very stiff, not a lot of movement in there. Now, both of these people, what was going on underneath their skin was very different. However, they presented with more or less the same symptoms. So that really got me thinking. And then it was complete serendipity. This was in the 1990s, and I went on a really early kinesiotape course, because again, my athletes kept babbling on about this colored tape that they'd seen their famous athletes wear, and could I use this? And of course, I had been using elastic taping and mechanical taping and taping to enhance movement. We didn't call it kinesiotape, and it didn't have fancy colors, but we were using that concept of actually moving the skin above and putting that little bit of tension on the skin, and things seemed to shift. We didn't really know much about it. So I really wanted to go and do that 𝐒𝐤𝐲𝐲 course really to prove my athletes wrong, because I felt at the time that it was snake oil, that it was commercial exploitation. And so I went on it and I started using it and noticed that, yes, when you are putting tension on the skin, is that me?
It's me. I'll say it's me.
Okay. Putting tension on the skin and keeping that tension there for a sustained period seemed to shift things. It made movement easier. It reduced pain in some people, in some circumstances. On one of those 𝐒𝐤𝐲𝐲 courses, they showed us using ultrasound. So they put the tape on, they put the scanner on, and then you could actually see the tissues underneath the scanner were moving without us touching anything. I thought, wow, maybe I could use this to try and look and see what's going on underneath the skin. And at that time, I was starting to read Hélène Langevin's work. I went to visit her. I showed her the ultrasound techniques that I had developed in the meantime, and really started to develop this more and more. And then I had the opportunity to apply for a PhD. I did my own PhD whilst I was already teaching sports therapy and sports rehabilitation at the university. So really, these things were happening in tandem. And then, as you mentioned, there was this kind of explosion of this really early fascia ultrasound research. And then it kind of came to a halt. But I carried on asking questions and trying to figure out what exactly was going on. Because we know that things happen. Things change for some people in chronic pain. For some people with movement restrictions, is whether we use manual therapy, whether we use exercise, whether we use taping, whatever mechanical force we apply, something happens. So, but one of the really big issues for us still at the moment is to visualize that. That is still a really big problem. So I think the gap for me that it's still we need to bridge is the difference between what therapists, whether they are rehabilitators, whether they're exercise specialists, whether they're massage therapists, yoga teachers, Pilates teachers, notice a change. When you put a mechanical stimulus in there, something happens. We still don't really know how to visualize that and how to measure that. And really to be taken seriously or to be incorporated into other really big scientific fields, we need to visualize it. We need to have biomarkers. We need to have very clear frameworks to say, okay, this is what a healthy fascia looks like, and this is what a pathological fascia looks like. We still don't really have that. That doesn't mean that, fascia doesn't play a role. It just means we haven't quite developed the tools in order to measure those changes. I know I'm veering off a little bit, not really talking about me, but that's really how I, what still, gets me up and go to work every day. And that's what's been such a pleasure, for example, working together with Claire on her program, because she really pushed it forward. And she started to look at fascia in movement and fascia in exercise. And okay, we know that things don't happen quickly. The turnover of collagen changes within the hyaluron, the extracellular matrix, the fluid part of fascia. Those changes take time. So we've looked and tossed and turned and measured fascia in so many different populations under quite a few different circumstances. I then had another master student who then looked at a very, very short term, little bit of flexion. We tried to see whether we could see any changes between a pain population and a non-pain population. And with each study and each student that I work with, we inch forwards. It's very, very slow. It doesn't mean that it's not worthy of investigation. It is, but we still need to develop the tools. So from that super excitement way back in 2009, 2010, we sort of thought, oh, by now we'll have all the answers, and we don't.
We're still working it out.
What we do have is people from very different scientific areas are now becoming interested and are seeing connections. They might not call it fascia, but that's basically what they're working with, and that's really exciting.
feel like you pretty much summarised my talk at the Therapy Expo there. Pretty much every question I was like, well, we don't know, but we think this and we think that.
Yeah, I think it's really important because it is easy to polarize this area. And I do think it's very, very important that whether you're a massage therapist, whether you're a Pilates teacher, or a yoga teacher, or an exercise coach, that you understand that this tissue is ubiquitous. It is absolutely everywhere. It is like a second skin underneath our skin. It is very closely related to our immune system, and it has a role in fluid dynamics. It has a role in pain. It has a role in movement. So it interacts and it communicates with so many different systems, yet it's very, very slippery. It keeps slipping through our fingers because we still can't quite measure it. Gold standard measurements in imaging, in musculoskeletal research is MRI. We still can't really measure. Ultrasound is still much, much better at visualizing fascia compared to MRI, for example.
I think that's just kind of, you're probably gathering from listening, Kyra and my kind of, our heads and the way we think about things, the way we teach, the way we research is trying to find, okay, well, we don't think this is everything, but it's connected, right? And we always think about fascia as that connection, as that whole body, and it interplays with everything. You know, we're not saying it connects everything equally, but it's involved, right? It's somewhere there, it's doing something, and we're still, us and all the wonderful fascia researchers are trying to put those dots together and go, that's it. And I still think it will happen at some point. We'll find that's how it connects, and we'll all have a party, I swear, all over the world. But we know it's connected somehow, and it's just trying to fit that together and see how and why and where. In my mind, anyway.
I compare it a lot with, for example, ligament research or cartilage research. If you think about what cartilage research was like, say, 50 years ago, people kind of discounted cartilage. And we still don't really understand, for example, why cartilage injuries are so painful, yet there are no nerves in there. There's no neural inputs into cartilage, yet it really, really hurts. So there is, again, that communication system. So I think I'm a very patient person. I think you need to be as a researcher, and you need to keep chipping away at it. But that doesn't mean that there is nothing to discover. We haven't quite turned the stone over and kind of seen the treasure, but we are chipping away at it because we know that our answers are somewhere in there, specifically for those type of conditions that are still so difficult to treat. And that we try and do our best and help people, but are still very, very difficult because it's not just purely muscular. It's not just purely psychosocial. It's not just purely the nervous system. It works together. It's not just purely training and strength. It's fascia touches on all of those elements. Makes it a nightmare to do research, but it's of course very fascinating, and it's an absolute treat for sports therapists, for rehabilitators, exercise specialists, and massage therapists, because practitioners work with all of those systems together. Probably they may or may not realize it, but so the changes that people can feel, therapists can feel underneath their hands, or can see in terms of changes of range of movement, changes in agility, changes in responses, absolutely are there. And those changes are there because it's different systems interacting with each other.
I love the way you both present it. For anyone listening to the podcast, you've missed 13 minutes of smiles whilst talking about fascia, and both of you had smile from ear to ear, and you haven't stopped because it's so infectious, because you're obviously so passionate about it, and you've had like a 24-hour day of non-stop education and stuff. So no, it's wonderful hearing everything you've said, and thank you so much, Kyra, for the timeline you gave. It was so interesting hearing how, I think for me personally, my confirmation bias is just hearing that you came from a skeptic's point of view with like kinesio tape and stuff and other types of tape, where you were like, hold on, I'm just going to do this because I know it doesn't work. And then you started looking into it. And that's such a healthy thing to hear. I think it's needed so much 15 years later when, like you say, it has become very polarized, like everything else in society, and people have given up on it. So yeah, very exciting. I just want to say, Sherry Phelps, good to hear. First time listener, little shout out. First time watching an STA live. Hi from Podium Therapies. Thank you, Sherry. It's interesting as well, and I'm sure it's because of the passion you're delivering. Is I get to see like the YouTube listeners, and normally they go up and they go down again. Everybody who's joined is just like stuck and glued, and they're like, oh, hold on, So it's what we need, I think, with a topic that can be so volatile and people switch off so quickly and don't kind of make the effort. So. Right then,
I think early on there was a lot of misinformation, and I think lots of different modalities really latched on to that very, very early research where myofibroblasts were involved, where the nociception and that relationship between fascia and pain, the relationship between cannabinoids and fascia, the fluid dynamics and fascia. So there was all this really early cell-to-cell communication within fascia, changes in collagen turnover. There was all that really exciting, very new early research. And I think lots of modalities kind of thought, oh, this explains what's happening. Bone therapy, lots and lots of visceral manipulation, lots and lots of different kinds of therapies, understandably wanting to have a framework, a theoretical framework to justify and to explain and to make sense of what they could feel was happening underneath their hands. And then it kind of stopped because the research could never provide evidence that that is what's happening in those therapies, because it is so difficult to actually justify that, because so many different systems are involved. And, is it the tone of our voice by which we talk to people? Is it the amount of time that we're listening to people? Is it the pressure that we're putting on the tissues? Is it the amount of dehydration and then rehydration of the tissues? There are so many different elements at play. Now, the beautiful thing is that so many therapists seem to know instinctively what somebody might need. Now it's up to the science in a way to catch up with that and to try and make sense of what happens and to find the tools for doing that. That's still really in its infancy, both in terms of the visualization of fascia and the biochemistry, the cell-to-cell communication, the role of inflammation in fascia. There are still so many elements of change that therapists just work with as a matter of normal. This is normal for many therapists, that they see these things change. But in scientific investigation, we can't just rely on case studies and case series. This is a great starting point. But then we need to look and look a little bit deeper, literally underneath the skin, to try and understand what is a healthy fascia and what is a pathological fascia, and how does that differ in the body? How does it differ across the age of people as well, for example?
This always links with how I know is how me and Kyra, and I think a lot of other lecturers teach and talk to their students, is we're always asked by students, by our patients, well, what's the best massage I can have? What's the best exercise I can have? What's the best da-da-da-da? And the answer is pretty much always, well, there's not which one are you going to do regularly? There isn't a best size fits all. It's going to come down to, what are you going to keep doing? What are you going to enjoy doing? What are you going to put that effort in even when you're tired? And that's what I'm always trying to come back to, is ultimately, in terms of fascia, we don't have anything more concrete than do what's good for your body. Like, we know movement is good, but we can't say doing this particular method is the best one, because it might well work, but we don't know if it's better compared to 100 other versions. It's just, what are you going to keep doing? And that is what I'm always coming back to, is that we haven't found anything that's the best yet, but we know that these things are working. So let's keep doing it, keep moving and adapting to what you're finding when you're treating these patients. If it's working for them, keep going because it's doing it, and everyone's so individual and so different that's what we want, right? They're going to keep coming back to you as that therapist, as your researcher, as your physio, as your scientist, personal trainer, whatever it is. If it's working, it's because you're doing something right for that person and that body. And that individuality is something we really have to, I think, dive into, which makes it hard for research. But in terms of us doing work with patients, it works, right?
Yeah, it does make it harder for researchers, doesn't it? Because that's another problem, is it the classic way of conducting research? Go back to guys just doing research on guys. I mean, that's a classic one, isn't it? Where there's a slight kind of omission there. But it's tricky. It's getting a bit better. Look, hey, we've got both of you on the show. 20 years ago, they wouldn't have allowed women to talk about fascia, so it's fantastic.
Oh, come on, Matt. It's only 50% of the population that's missing in so much research.
Exactly. And we can mansplain it. We can, Anyway, so I'm interested then. We call this new perspectives on fascia. So you've laid a wonderful perspective on the idea that we don't know everything, but we mustn't dismiss everything. But if we can look now at maybe a couple or two or three things which you think clinicians should be taking on board to update their perspectives on fascia, things which maybe you think people have got wrong, whether it's they're overdoing it on something old which is kind of moved on from, or maybe they're underdoing it because they think that, there's no point touching this, I can't affect fascia. What do you think we should talk about? Two or three things.
I mean, we sort of started, I sort of started on movement there, so perhaps we start there in that I think the issues when I have discussions with someone that comes up to me and goes, fascia, and I'm like, yeah, did a whole PhD on it, it's a real thing. They're usually just, but we don't know what's best, and that is the one that comes up a lot. And it's trying to remind, I suppose, people that we have found research that so things are changing. My PhD is still not published for the intervention I did, but I had lower back pain. I did lower back pain classes for 6 months. We did it all online because it was COVID era, and they had a reduction in pain. So we didn't see any significant changes in fascia. It changed, but it didn't cross that magic number. I think we needed more than 6 months, but that's another whole problem. But their pain reduced. So maybe we need to look a bit more broadly and go, okay, well, what do we know works? We've got loads of evidence that looks at how muscle adapts to different types of exercise. And I'm talking cardiovascular, I'm talking strength, I'm talking flexibility. Again, that there's no one size fits all. We know it works with bone. We know it works with ligaments. Think about injury rehab. We know that these things are working, and it's trying to get that thought out of people's heads that are I can't do anything. It does take a long time, and I'm not going to argue that it doesn't, but if you get people into those habits of those movements and those massages and whatever it is you're doing that are, we know, mobilizing, we know they're encouraging those multi-directional movements across the body, that's going to hopefully make those lifelong changes. And then they might still be doing that 6-12 months from now, and then we start to see the fascia change. So that's something I think it needs to shift back, because it was, you must do this exercise and this will make fascia work, and then that didn't kind of follow through. So then it became, it won't do anything that aims at fascia because it won't do anything. And so we've gone one end to the other, whereas I want us in the middle somewhere. I want us to middle and work between both and see what happens. I don't know if you agree, disagree, Kyra. I think you're going to agree.
Yeah, I think really it's about, from a fascia practice point of view, needs a very different approach to fascia research. So for fascia practice, what is important is that you understand which layer are you working with. I think what's really interesting is that we are becoming more and more interested in the superficial layer, which is basically the space between the dermis, the epidermis, the fat. Those fat lobules, they sit inside pockets of dense connective tissue. Within that dense connective tissue, there's a layer of superficial fascia. Now, on the thousands of scans that Claire and I have been doing, we can measure, and we can see distinctive different patterns of that superficial fascia. Whereas traditionally in fascia ultrasound research, the emphasis was on the deep fascia. For example, the thoracolumbar fascia, that thick pad, that kind of diamond-shaped, thick connective tissue pad in the lower back, where when you put the scanner on there, you can get somebody to do a Superman type of movement, and you can see all these layers sliding over each other. So the original thinking was, oh well, actually, that's really where the answers lie. Now, we've been scanning people for thousands of different scans, yet the changes that we see is not in that deep fascia, but it's in the superficial fascia, where that superficial fascia is very organized in some people and very, very disorganized in other people. Sometimes the disorganized fascia is indeed in people with lower back pain. Sometimes the really disorganized fascia is in people without pain. Might be a precursor, it might not. We need to do follow-up studies in order to find out. Now, as a therapist, as a fascia practice, it is important to have the conscious intention to understand that when you are doing a fascial technique, or when you are using plyometrics, or when you are stretching, or when you are doing whatever training you might be doing, when you're doing strength training, for example. So to think about the relationship between these different layers and, for example, the muscles. As Claire mentioned, a lot of the fascial techniques sometimes claim that they are only addressing the fascia. In my book, it's not really possible. So when we're talking about strengthening, you are looking at strengthening the muscles, but you are also looking at changing that relationship, either creating less stiffness, less adhesions, less densification, or doing the opposite, actually trying to get that fascia to tighten up a little bit, because that will enhance that force transmission. So I think there are two things in fascia practice, is to understand that relationship between the fascia and the muscles. We can't really separate them. They act together. They slide over each other. They either don't slide over each other and move as one unit. And then that relationship between, it might not be the deep fascia, so it might not be those really, really deep treatments that are necessary. It could be that actually very light touch, or a different input, maybe more of an interplay between the nervous system and the fascia and the fluid. That's what might be necessary. So I think we're still at the stage where very, very deep treatments, that's what might be needed, or more lighter and a more superficial and very light touch. That might be what's needed.
Okay, we've got some great questions coming in on basis of what you've both said. So, you ready for questions here? And we've got some good questions in the house. So that was like a little warning here coming on. Let's go. Cecily Hislop, first of all. I'll bring it up on the screen for people who are watching on YouTube. Cecily says, so to put it in blunt terms, classic Cecily, how can touch massage affect fascia? Particularly in the US, you'll hear the term melting fascia, which makes me cringe. So what does actually happen? Many thanks. Smiley face.
Yeah, I also don't like the melting fist up, but you can't melt it. It's part of your body. We don't want it to disappear. We just want to mobilize it. I mean, we know from when we're doing massage treatment, if I'm ultrasounding at the same time, you could see the kind of how the muscles and the fat and the fascia all kind of bow. It's the same even when you do anything. If you touch something, everything interplays, right? So the way I see it is, we're not melting it. We're just trying to mobilize. And linking back to what Kyra said there, really, when people are saying they're just targeting fascia, no, you're not. You're targeting skin, you're targeting muscle, you're targeting everything. And that's not a bad thing. We can't separate it. We're not trying to. We're trying to move everything. We're trying to get everything moving and mobile, because we all know if you've got DOMS and you can barely move, everything feels wrong. You do the penguin waddle out the gym, don't you? And it's like, if I could just get that all to move properly, it's not a problem. So I think we can see it under ultrasound. We can see the kind of changes that we're putting that pressure on as we're moving up and down the body with those massage strokes. We're not melting it. We're just trying to get it more supple, more mobile. We're just trying to get it to do something, because sometimes it can get very sticky, and it looks like cotton wool sometimes under ultrasound, which I should have brought some scans in. We could have pinged them over to you, Matt, but next time.
You've done a great job describing it. So, but have you seen then that different types of touch and strokes do affect the fascia in different ways? And is that just, or is it random?
No,
not really
we
different.
haven't. The changes. So just to go back to Cicely's question about melting, I also think that concept of melting is probably not meant literally. I think it's a concept whereby a very light touch or a very prolonged stretch, similar to yin yoga, for example, these very prolonged stretches give the sensation of release. Now, that release in that short period of time is probably not going to be that deep fascia.
No.
When you do dissection, you have to take a very, very fresh scalpel in order to separate that deep fascia from the muscles. In order to kind of look at that relationship between the intramuscular fascia, the perimuscular fascia. Don't want to get too technical about it, but it is basically everywhere. So melting it or stretching it is probably not what's happening. But people doing these techniques feel different. They feel great. So what might be happening, that it's actually an interplay between fluid changes and fascia, or it's an interplay between the nervous system and fascia, because of course stiffness in muscles, and you mentioned DOMS earlier, that pain in muscles is not just the muscle fibers, it's the nervous system, it's the immune system, it's the fluid system, it's inflammation. So could it be that these very slow, very prolonged stretches somehow have a neurological effect, which reduces pain, which then allows us to move a little bit more freely? Now, that doesn't mean that those techniques don't work, but they might not just be working on the fascia. And that's why I think people have this immediate release. Whereas if it would be working only on the fascia, you would have to hang there for a very long time, or you would have to kind of stretch for an incredibly long time. Yet when people do those techniques, they feel the release immediately. So in my mind, it's a different system. It doesn't mean that we have to disregard fascia. There are still adhesions within the fascia. There are still densifications. There are still changes. But maybe we need to address those changes by working with different body systems, like the fluid system, like the immune system, like the nervous system. So that's what I think is happening there.
How about, because one of the reasons that I think fascia courses lost favor with maybe the more some of the scientific community was the really painful techniques, like the picking up the skin and the rolling. And I've been on courses back in the day where it was a case of the person underneath just had to, we were doing it on each other, and it was so painful. I can't remember what it's called now, but literally lifting up the skin and picking it up. And it was all very structurally based. We were told what you're actually doing here is you're separating the fascia and actually lifting it up. And it was so painful. And you had massive red marks afterwards. And that was used as evidence that something's happening. The fact that there was like...
Absolutely. And that is exactly what you were doing. So you were breaking up that superficial fascia. You were releasing an awful lot of inflammatory cells. You were causing bruising. I mean, I was covered in bruises myself when I did those courses. And again, this idea of it produces so much pain, therefore it must be good for us. And yet it's that loop, it's that experience of pain, and then of course the reduction in pain, and then maybe or maybe not a little bit easy of movement once that bruising, the swelling had gone. But that skin rolling and that picking up and kind of tugging at the skin, that's exactly what we were doing. We were breaking up that those very, very delicate, almost like a honeycomb of tissues.
For how long? Or was that a difficult question? Is it a temporary thing? Like any structural effect it did have, would it, as soon as they stand up and start moving around, would it go back to how it was? Or do you think there was any therapeutic benefit in terms of loosening things up?
It depends. depends on what you do afterwards. So if once you kind of have that release as such with those very, very painful deep techniques, if people then went back to not moving their bodies, everything probably just went back again. If that would then allow people to start moving a little bit more, might allow them to go maybe for a walk, or to do some exercise and to enjoy exercise, or to have a continuation of movement and exercise. Sure. So if it's like a gateway towards another change, absolutely. But just of its own, to having to keep going back for those very, very painful treatments, it wouldn't be my first choice.
It's the kind of argues that is it necessary to, like, the way we teach, both Kyra and I teach massage to our students. We teach them in the first year, and then we follow up with a follow-up course later in their degree. We're always telling them to stay within certain pain ranges because, one, they're learning. We don't want them to hurt each other, but we don't want them to go out and cause loads of pain to people, because it doesn't always make sense. If someone's doing a really painful treatment to you, I bet you're bunching up your shoulders, you're probably clenching your fists, you're gritting your teeth, and actually, well, how is that helping you to relax those muscles? That your whole body system, it's causing the opposite effect. So it's a really good.
The one kind of situation is, for example, in post-surgical fibrosis, particularly around the knee, around the elbow, around the shoulder. When you're working with those joint capsules, sometimes a very deep, a very acute stretch or manipulation can help, as long as people then carry on moving those joints and keeping active. So there are situations where I think those very deep techniques, which can be painful, are really, really useful. Again, as long as it's followed up.
And how does this, because back in the day, it was the Chowdhury paper, 2007, I think, which kind of took great delight in quoting, how many newtons it took to deform fascia by 1%. I think it was on nasal fascia and stuff. And they cut on paper, it showed that whatever you think you're doing to fascia, you're not. But you're suggesting that with the picking up of the skin, we are actually kind of changing the state of the fascia.
There's two different things. That picking up of the skin and tugging at the skin and the skin rolling, where we were told at the time, look, this is where it's very, very dense, and this is where it's adhered, and so on. And this isn't, a lot of that is just different thicknesses in layers of fat in between the skin and the muscles. And that differs all across the body. And that's important that differs. So, for example, over the hamstrings, it's meant to be tight. Over the shoulder, it's a little bit less tight. So a lot of those differences are functional. But what I think we were doing is we were changing that relationship of that very, very thin, that honeycomb superficial fascia, right in where the fat lobules sit in. We were changing that. We weren't changing the deep fascia, because you can't really do that. So when we talk about fascia, that goes back to my earlier point about nomenclature and about what it is that we're calling. We shouldn't just be talking about fascia. We need to talk about, are we talking about the superficial fascia, the honeycomb network, or are we talking about the deep fascia? Are we talking about visceral fascia? Are we talking about intramuscular fascia, the fascia inside the muscles? So all those different layers and different areas of the body require a slightly different approach, depending on what the role of fascia is. Is it to aid gliding? Is it to help force transmission? And should it be stiff so that it can aid that force transmission between muscles, for example? So I think it is different. And with the post-surgical fibrosis, I think that relationship between skin, joint capsule, ligaments, tendons, fascia, it is all collagen. It is all connective tissue. It has a slight contractile ability, but its main function is very, very different from, for example, muscles. So it requires a different technique. And sometimes, shifting that capsule, or it might be that what we're doing is again talking to the nervous system. And it might be that, certain end plates kind of switch and turn from nociceptors to mechanoreceptors, which is, I think, blows my mind. I think it's absolutely incredible that our body can do things like that.
Yeah.
It might be that we're putting different inputs into those nerve pathways, and that aids that easing. So again, it takes us back to that idea of melting fascia. We might be talking to the nervous system, which will then allow a little bit more sliding, or allow a little bit more movement, pain, with reduced pain.
That does sound like an important avenue to go down, because again, I think people are still taught like cross friction and the whole kind of like Cyriax method, and the idea that by really putting two things in the other and really pushing, you are breaking stuff down and over. And again, back in the day, I remember like with Achilles tendinopathies and things, we were told kind of, and it's so painful. But I guess, it's just trying to move away from that idea. James has kind of asked a great question. James Morgan from Barefoot Physio, along the same lines. James says, so what's the premise of specific changes that to fascia with regards to pain? Is it possible to be specific? How do you separate fascia from inputs to the nervous system and the contextual factors that go along with the patient's experience? There's quite a lot in there, isn't there? You can rely on James Morgan to come up with a, It's not going to be an extended episode for an hour. Do stay with us. Good one, James. Yeah, what can you comment on that?
I mean, for me, it's with difficulty. That's the answer to that question, is because anything with people, we're alive, we're living, we're doing, we're breathing, we feel things, how can we quantify it? And that's something we are, I think we'd be asking that question for an eternity, if I'm honest, because how can we, and it's trying to think of it in all of those avenues is something that's important to me, because that patient experience might not be, I might be scanning you on an ultrasound and going, well, actually it looks fine, but it's not if you're in pain and you've had issues, you've got nothing coming up on your x-rays, your MRIs, whatever it is. But if it looks fine but it's not, something's happening, right? And it's that patient experience is what we're trying to get to the bottom of. And at the moment, the honest answer is we don't have a way to do that. We don't. I'd like us to one day. I'm not even sure we will. I think I'll be researching this forever and trying to work it out. And I'm not unhappy about it, because I want to find out more. I want to get more into it. But it's really hard to be specific and how to separate, because we can't separate it. It's connected to everything. We're one thing.
But are we closer to a way of saying that this person has got a problem or an issue that is because it's fascia orientated?
Not really.
No.
We still don't have, because one of the problems is that we still can't, we still don't really know what the biomarkers are and how to visualize and how to image and how to measure and what the parameters are of a healthy fascia. We still, and those early studies which mentioned 25% of people with chronic lower back pain, their thoracolumbar fascia is 25% thicker. Now, when we did our studies, we didn't find that at all. Subsequent studies didn't find that at all. And it might be that what was being measured was the dense connective tissue, but also the fluid and the superficial fascia. And in those days, we didn't really distinguish between, we either discounted the superficial fascia, was discounted in research papers, or it was kind of lumped in together. So again, that's, what you mentioned, the specific changes to fascia with regards to pain, we still can't separate that. But that doesn't mean that we don't consider it or that we don't take it into account. It's not because we can't diagnose it as such at the moment that we discount it. So, for example, that the fascial connection between different muscle groups, the connection between the muscle, the musculotendon unit, the attachment onto the bone, those are real. Yeah, those are real anatomical structures that I don't think anybody is questioning. Now, when we are looking at how to separate fascia from input to the nervous system, there is a really interesting study of the University of Auckland. And what they did was they tried to visualize fascia in MRI scanners. It's very, very difficult. They tried it with contrast fluid. It's really, really difficult to look at what is fascia, what is fat, what is it all comes up as white. Yeah, it all looks the same. Then what they did is they stimulated the fascial layers with an acupuncture needle. And all of a sudden it started lighting up. And they could see the difference as to where the fat was and where the fascia is. So these are really, really early studies. So we are still at that really early stage whereby we are putting a stimulus into the fascia. Now, whether that's lighting up because of that mechanical stimulus or whether that's lighting up because of the neural input, we still don't really know. Again, other studies are finding out the difference between very superficial, this is on the cheek of a mouse, very, very superficial stroking and looking at which neurons are lighting up. And then applying a deeper pressure, just with like the thing you clean your ears with. And then a deeper pressure kind of going into, this is being imaged at the same time. This is on a sedated but live mouse, so not a cadaver. And a deeper pressure. And then when you look at which neurons are being activated, it's a very, very different pattern. So we're only at the very early stages whereby we can visualize and measure what happens to the nervous system when we do very light touch. And it's a very different pattern than when we apply a deeper touch. So that goes a little bit towards answering your question on inputs to the nervous system. And then the last point of your question for me rounds the circle. And that is those psychosocial context of pain and restrictions and holding on. And for me, that's a really exciting area whereby we put together the mechanical inputs, the psychosocial changes, and the structural changes. And for me, the answers lie in all three of those things. And that is what therapists have been working with in a holistic manner. So rather than separating them, I think it is about bringing those systems together. And from a theoretical perspective, is to understand the interplay between all of those systems. Now, for Claire and I, this is not something that we do at the level of research that we're doing. We are still trying to figure out the best medical imaging techniques in order to measure pixels, in order to look at changes in fluids, in order to look at changes in the shapes of the fascia that we are imaging. So we are still very much working with ultrasound and fascia. At the same time, conceptually, we are very aware that this is not just structural changes, that it's the nervous system, and of course, the socioeconomic and the psychosocial circumstances of somebody who is in pain.
Thinking on the structural side, sorry, jumping one more. So our lab's not, it's me and Kyra currently, it's a small lab, a little undergrad student. So we're working on this bit by bit, but I mean, fluid is something that we're very interested in, and we are currently a bit limited with how we can get in there and all the rest of it. But the research coming out from Kyra De Coninck and Katerina Fede are really looking into, and that's the past 5 years or so, it's really started growing and growing. What is that fluid made of exactly? What is in there? How is that starting to be different in different kind of age ranges? That, like, Kyra did one that looked from pre-birth and all the, like, there's been various different bits that are coming out that's very much new in terms of fascia research, that's trying to get us to get that little bit more understanding. And I think what we're all doing is trying to just find that little bit more, so then we can build it. It's like we're playing with Lego the whole time, and we're still trying to get to the, okay, well, we know this, but it doesn't quite make sense here. Okay, what if we put this in? What if we put that in? And build that kind of picture. So the new research that I've got my new students doing, which Kyra's helping me out as co-supervisor as well, we're looking at how fascia changes under ultrasound, the same technique we've been doing, so it's the same thing still, but okay, well, how does that change through the menstrual cycle? Because we haven't looked at that yet. What is different? What are we building? And it's all trying to find new bits, because we can't, there's only so many of us, we can only do so much. But I think every researcher is coming across it in a different angle, and we're all trying to work together, I suppose, to try and find these answers so we can get a little bit closer to quantifying more things and the connection between them. But it's really hard.
As you said, it's stressed. So we're going to have to do, I'm saying we have to. It'd be lovely to have you back for part 2, because there's so many more questions. But I'm interested with this episode. We've talked about some of the new perspectives on fascia, and it's so exciting to hear what you're working on. And what are some of the take-homes for clinicians then, in terms of, thanks to the new perspectives you've talked about and ones which we probably haven't even mentioned, what do you think the modern clinician should be doing, or even shouldn't be doing, in order to make the most of what could be happening? We don't know exactly what's happening yet, but just to make the most of potentially affecting the fascia and helping.
My number one will be talk to your patient and see what are you doing? What are they saying is working for them? What is improving it? Be that movement, be that massage, be that various different techniques, mobilizations, whatever it is, and go from there. Make those notes of what works for that person. It probably won't be the same for that next person. And going back to trust your gut, you can read 100 different journal articles, and I encourage you to. Your new research is great, but actually applying it is sometimes missing in the research, and we're trying to do that in our avenue, but not everyone is, because not everyone can be a researcher and a practitioner. We're all too busy for that. So it's trying to find, okay, well, how can I get that and put it into mine? What is working that I'm doing that might interplay? And I think having that open mind that, okay, well, it's working. I might not know exactly why, but it's working. So that's my big take home.
Okay, so are you okay for time, by the way? It's 9 o'clock. I don't know whether okay for another 5-10 minutes, because I want to give people kind of the 3 things to take home. So even though we don't know how things are working, we are getting closer by the sounds of it, which is thanks to people like yourself. In order to successfully potentially help somebody with a fascia situation, even though we can't label it then, it really is a case of working in a patient-centered model where you're asking what works for them. And then the chances are, by giving them maybe a technique which you've poo-pooed in the past, like rolling or whatever it is, if that's working for them and it's giving them results, then kind of believe your gut and stick with that. That's kind of the take-home message you've got from a lot of the research you've done. Keep going with what your patient says is better, because it is very much an individual thing. And one day, maybe we'll know why. That's why that worked for that patient and why it didn't work for the other one. But at the moment, it's just let the patient guide you, because we haven't really got an explanation yet.
Yeah, absolutely. And I think not to put your eggs all in one basket, and to be very open-minded, and not to think that because something worked with one person, that therefore this is the technique that you now identify yourself with, and this is now something that you apply to absolutely everybody. So it is still very much a case of very individualized approach. And then I think to really think of fascia as something that works together with other systems. It's not something that just functions on its own. I think that's really important. So not to disregard muscles, not to disregard the immune system, not to disregard the fluid system, not to disregard movement and strength, and that these all work together. It might be that actually preparing the body for example, strengthening or for agility, that actually these fascial techniques might really help to prepare the body to be better equipped to cope with rehabilitation, to cope with maybe those deeper techniques, to cope with strength training or whatever, or plyometrics or whatever it is that you need to do with your patients. So I think fascia can be a very helpful framework to think about restrictions, to think about pain, to think about densification in certain areas of the body, to work with those, to then prepare the body for further treatments.
Okay. And one more? What else would you like therapists to be taking? Like, I haven't got enough from you, but what else do you think?
to be really, really patient. Remember, connective tissue is very, very different from muscles. Muscles, you can feel when you put a mechanical stimulus into it, you can almost feel that change. With fascia, it takes time. The collagen turnover is very, very slow. So I would say, particularly with people with very chronic pain, is to be patient, to work very incrementally, and then to look at how the patient responds. Is to allow for that work to settle in, and not to always expect short-term outcomes. But people know this.
Well, no, I think by poo-pooing kind of fascia techniques, then people are moving away from those slow kind of hold your hands on there and imagine. I remember I was given the kind of idea of it was like a pound coin melting in a tub of margarine and just giving it that moment. And if you think, well, is anything actually melting under my hands? Then probably not. And you think, oh, I'm not going to do this anymore. But like you say, you could be affecting the fascia doing this, but for a different reason, mechanism of action we don't know yet.
Fascia.
Yeah. So if you keep trying these techniques on your individual, don't go in there with I know how to sort you out. See if it feels nice to them, see if it helps with their movement and stuff, and then keep going with that, because that could be because we're working with different.
And also I don't think those techniques need to be thought of as a standalone technique.
No.
I see them very much as an entry into other things that people can do themselves in their own lives. You should not have to go and have, fascial treatments for the rest of your life.
No.
Though lots of different professions will come and shoot me now, but
I'm going to hit you with one hard question now. I think it's a hard question, but I hear it a lot, and I'm interested because there's two of you. I wouldn't do it if it was one of you, because there's two of you now. You can take this now, and it is from Mr. James Morgan again of Barefoot Physio. And I hear this a lot, so here we go. James says, if it's a frictionless interface, then how can you create any significant structural change?
Well, we haven't yet. We're still trying to get that significance, but what we're looking at is that it's going to take a very, very long time. And the study I did for my main bulk of my PhD was a 6-month study, and it was exercise rather than massage thing. So obviously you could argue perhaps a hands-on would have had a faster approach, but we saw changes, but they weren't statistically significant. But we saw reductions in pain, and those people were saying and telling me from these discussions, I managed to walk my dog for a mile, and they're like, I haven't walked more than 10 meters in years. And it was just like, that's amazing, and they're still in contact with me on Facebook. We still check in. So we don't quite know how to make that significant structural change yet. I don't.
Yeah.
I wouldn't really call it a frictionless interface, because it's not frictionless. That gliding is not endless. Yeah. So there are restrictions within the interface, and some of those restrictions are actually really important and should not be broken down. But at other times, when it causes pain and when it causes a reduced range of movement, for example, then maybe some fascial work could actually ease that movement and increase range of movement, even if it's temporarily, to then allow that rehabilitation to take place. So this is a really important point. Significant structural change. So we don't see any significant structural change as a result of a short-term mechanical input. Be that massage, be that Graston, be that whatever. So what we do see is some changes in fluid, but that deep fascia does not change. We don't see change. We see some changes in the superficial fascia, but not in the deep fascia. And that's what gets me thinking. Then it's obviously what we are seeing, because I do not want to trivialize a patient's experience. They experience a reduction in pain. They experience an increase in range of movement. We cannot discount that. But that might not be because we made a structural difference to the fascia. It might be because we are changing the neural input into the fascia.
Okay.
So I think it's more along those lines. But we do not have any evidence that what we are doing is structurally changing the deep fascia.
Wonderful, great answer. I was worried about that one, but it dealt with it wonderfully. No, it's great.
Don't be worried about any question.
Well, no, I haven't spent time with you before, Kyra, so now I know that you're hard as nails like Claire. So yeah, I should have guessed.
In our pre-talk, we kept talking about the importance of touch as a massage therapist and as anyone treating people, and I think that still comes back in here as one of the take-homes again. Don't be afraid of touching your patients. They generally like it. They generally find it helps them understand what's going on and helps them feel better. I think it's a really important thing.
Anything that we can do to get people moving is good and is beneficial. And what we're trying to understand is what this connective tissue, what the role is. Yeah, absolutely. So we're not looking at smoothing out your fascia or untangling your fascia or anything like that. Those short-term changes are probably quite temporary, but they could be very significant to get somebody moving or to get somebody to experience a pain-free movement, which is incredibly important as a starting point.
Yeah,
definitely. Yeah, in terms of behavior change, I mean, some people hate that idea of, what was the phrase which was going around? I think it was something to do with a window, opening a window, or it's a window of opportunity. That was the one that got really kind of slagged off by a lot of other kind of who would call fascia people fasciists when it's that kind of era. But there is windows of opportunity. I don't think we're coming around now and understanding all the principles of coaching and behavior change and person-centered care. It's a beautiful analogy, the opening window. We don't literally mean you're opening a window, but that really sums up in this person's life where they've never been able to lift up their grandchild or been able to do something really meaningful. If they can do it that afternoon, poof, who knows how that's going to knock on effect of what they could believe they can do and witness they do. So
absolutely, that's exactly what I remember talking to Claire about when we were doing the statistics, and statistically there was no difference. Then when we looked at the experience of these of the 6 months of training, and that was life changing.
Then I was happy.
Incredibly, very, very meaningful. And now we need to figure out whether it also had an effect on the connective tissue, because it was so, such a long intervention.
Great stuff. Okay, right. I'm very conscious of the time. Cecily Hislop sums it up very nicely in saying, thank you both. This may sound daft. Never, Cecily. Never accuse you of being daft. This may sound daft, but I feel quite reassured from your answers. There's such a minefield information out there that a simple clarification is needed. Well, that's nice. That's our goal, isn't it? Just to make therapists
just to
feel assured. And
I just want to give a little shout out for anybody who is interested in fascia research and finding out more about it. There is the Fascia Research Society. So check out, there's going to be webinars, there's going to be lots of things coming up. There's going to be a research cafe as well. So lots of things coming up. Have a look at on our social media over the next few weeks. We'll have more information.
We'll make sure that link, what is the best link for that? We'll make sure it goes into the show notes, but where should people go if they're listening now and they're ready to go? What should they go to?
FasciaResearchSociety.org.
.org. It's a .org. Okay, we'll make sure that goes in the show notes. Brilliant. That's very exciting to hear. It is such an interesting topic. I'm so glad it's coming round like a corner now and coming back and linking with other research with the touch and the difference between light and deeper touch and everything. So very exciting. Thank you so much, you guys. Really, really appreciate it. The way you present the information as well is so beautiful. So I really appreciate the time you've given us. And
we
thank you, everyone.
Talking about it, and
are you sure? I never got that impression. So I've never seen two people smile. Fascia. I'm trying to think whether you can. Yeah, you can say fascia with a serious face. It is possible. I thought maybe it was a fascia, but you can say fascia.
Say it with a big grin as well.
You can. Definitely, it seems a much happier word. I'm so glad, Cecily, that's really summed it up nice as well, because that is our goal on the STA podcast, is to try and help you amazing, empathetic people continue your job. Because if you don't have that confidence in yourselves, very difficult to help the person underneath you. Very difficult to guide them and walk next to them if you're not sure of yourself. So it's really nice to hear, Cecily. And maybe that will open a window of opportunity now and allow you to do great things tomorrow and then change someone else's life. So really good feedback. Thank you, Cicely. Right, fantastic. We will be here next week. And just to let you know, if you're listening to the podcast, we will be here on what date we can talk about. November the 14th at 8 o'clock. We'll be on the Sports Therapy Association YouTube channel and Facebook page with our guest will be Jenny Burrell, who a lot of you have done courses and you know Jenny, fantastic educator, founder of Burrell Education. A lot of people you know through courses of that to do with women's health, fitness and wellness. Jenny Burrell's also creator of Holistic Core Restore, which is a program designed to enhance pelvic floor and core health through movement-based exercises. And Jenny's also very much involved with coaching and self-care, and which is such a hot topic for clinicians as well, to look after yourselves, because it is a career and which you can really burn out so easily, giving all of your all to everybody else. So one way of avoiding that is just the way you approach it. You haven't got the responsibility of fixing this person. Give it to them. Let them talk. Let they figure out what the way is to help them. And that takes that responsibility off you. And you're going to get better results. So we'll be talking about all sorts of things like that with Jenny next week. So if you are listening to the podcast and you fancy joining us live because you thought, I want to hear some of this, I want to ask some people questions, then just come along to YouTube or Facebook at 8 o'clock on Tuesday. Until then, thank you once again to Dr. Claire Boucher. Thank you, Claire.
Thank you. Thanks for having us.
And also to Dr. Kyra De Coninck. Thank you very much.
Thank you so much. One thing I wanted to ask you is some of the questions. I haven't been able to read all of the questions, but there's some really great questions. Would you like me to answer some of them in writing and then you can post them?
That would be amazing. I mean, they'll be on YouTube. And I always encourage listeners, if you listen to the podcast and you do want to leave a question, go to YouTube and put it in the comments there. And I do monitor them. And then I can send them in a nice, easy to read format, because I know Claire and Kyra are super, super busy. But I'd love to. That'd be amazing of you. If I can send them to you. I know Nikki had a couple of questions and a few people. So that'd be amazing.
Some of those questions, and
so kind of you.
Give people some papers that they can go and read. And
kind of you.
I saw Nikki was after the one with the mechanoreceptors, so we've got to give her that.
We'll give her that. Yeah. Nikki says, great Tuesday night geeking, guys. Gracias. And Nikki says, yes, please. Yeah, we will come back to it. And maybe, who knows, maybe we'll have a part 2, because there's so much more we could have talked about. Right. Look at that. 9:15. I'm sorry. I kept you for 50 minutes longer. I'm going to close it down. Thanks, everyone. Take care of each other and take care of yourselves. We'll see you hopefully very soon. Bye-bye.